Very good afternoon, everybody. All those who are listening to me right now, and everybody who will be listening to this training after we are done with the live. So, I'm Dr. Himanshu Mathur from on the behalf of Jaipur Rehab. I welcome everybody of you, and we have our special guest of the day here, Dr. Amit Parwazar. I would like to give a brief introduction of him before we start and bestow this session to him. Although I don't want to waste any time for the day, because even I want to listen to him because he's such a wonderful teacher and such a wonderful orator in terms of pediatric neurology. I've heard him previously also, and I'm a great fan of him. Right. I would like to introduce Amit. You can just load up the volume, sir. Yeah.
Is it okay now?
Yeah, you can just switch off the volume actually because it will interfere somewhere for the online. Okay. Dr. Amit Parwazar is a BPT and MPD from SV Nirtar. Sir is also the member of IEP. Sir is certified sensory integration therapist from University of California. Sir is also certified in NDT from Boston University. Sir is also certified in advanced NDT therapist. Sir has certified OTP level first and second therapist. Sir is also certified autism movement therapist from USA. Sir is currently working as the director of Little Seeds Clinic, and Sir is the president of Chhattisgarh Pediatric Physiotherapy Association. It is really a pleasure of ours, sir, to have you on our platform. And without wasting any more time, I would like to bestow this session to you. The session is all yours, sir. Thank you.
Thank you so much, Dr. Himanshu. And first of all, before starting, I'm really thankful to you that you are inviting me on this platform to discuss about all these topics, because in pediatrics there are so many things to discuss. And I'm also thankful to Jaipur Rehab team. There are many good therapists who are working with you, and I'm really thankful to them also. I'm thankful to Dr. Anup also, who is managing all those things. And also all the participants. There are so many professionals also who are listening this lecture. Related with today topic, only few slides are there on my PPT, which is related with theory part. But most of the part for today discussion, we are going toward the lab, and we'll discuss about the techniques and how we can use in our clinic, what basic stuff we can use, whatever we have in our clinic. And if you have full-fledged pediatric therapy center, how you can use different equipment, mainly for vestibular rehabilitation in pediatric population. So today topic of discussion, we all know it's about the vestibular processing dysfunction. Sensory integration or the sensory problem, there are so many things to discuss, but just to concise in terms of vestibular processing dysfunction, we are mainly focusing today about cerebral palsy, children with cerebral palsy who are like having so many other issues like the auditory issues, proprioceptive issues, issues with the posture control, issues with the vision, and so many things. But there are so many other sensory systems also which are involved. Although we know in terms of definition, the cerebral palsy is the more a problem toward the motor component, but they have so many other secondary issues. The things are like sensory developmental issues, and also related with the epilepsy, sometimes the feeding issues, and so many things. So I am Dr. Amit Barua in front of you today, presenting about vestibular processing dysfunction, how we can treat a child with cerebral palsy who are still, after so many days of therapy, lacking in terms of some minimum component which is related with the neck control, sometimes sitting, sometimes standing, sometimes about our gait training. So vestibular processing dysfunction, we all know as a therapist and professionals that vestibular system is mainly related with our movement. Whenever we listen this word like the vestibular, we always correlate it with the movement. But there are so many other things how we can use this system for our treatment point of view, and how to correlate with other system. Like for example, we all know the vestibular system is it's very much mingled with the vision, with the auditory system. and so many other things. So and we also know that kids who are having like cerebral palsy, they have all these problems like the vision, the auditory, and so many other things. So by considering this system, especially the vestibular system, we can treat so many other things also. We can help other professionals also for their own treatment sessions, like maybe to we can help to the speech therapist also, to the vision therapist, and so many other therapists who are working with the children with the cerebral palsy. So as we know, in definition on my next slide, it is mentioned that we all know CP or the cerebral palsy. It's a group. It's not only the one component. It's a group of disorders. It's a group of so many problems together. It's a kind of umbrella term having some up, some down, and there are so many classifications for the cerebral palsy. But basically, the classification is based on functional level, the functional involvement of a child. So, as the GMFCS, which talking about the functional status, some kids are more functional, some are more dependent on the family or the caretaker. So definitely, the cerebral palsy, it's more kind of permanent disorder of brain due to the injury to the developing brain. But whenever we are talking about cerebral palsy as a physiotherapist, we always consider like maybe the kids are having motor issues like the tightness, like the tone problem, the asymmetry. But something is different in terms of treatment. If we are considering the treatment point of view for the kids with cerebral palsy, we have to consider so many things. So that's what the main topic of discussion for today, how we can correlate all these motor component and the sensory component which the kids with cerebral palsy they are having. If we can correlate these two systems together, like the motor component as well as the sensory issues, definitely the treatment will be much better. The outcome will be much better than your expectations, and maybe the family and your own data collection can be changed if you consider both the things. So there are so many books, there are so many researches which is coming out that the sensory problem, maybe the primary or secondarily. Most of these studies is done by Murray, and they have clearly mentioned in the book that the sensory processing problem may be the primary and secondarily. Primary is most of the time is the direct injury to that particular area in the brain. But today we are considering about the secondarily involvement of sensory system. And in that sensory system, I am going to discuss mainly about the vestibular system, because there are so many other things like the proprioceptive issues, the tactile issues, but today topic of discussion is more focused toward the vestibular things. On my next slide, it is mentioned about the definition. We all know that there are so many definitions in different books which describe about the term cerebral palsy. But one thing which clinically is important, it's about the functional level. It's about the status of that child, because whenever we are going to treat a child, definitely we have to be know about the functional status in terms of the scales. Like we are using 3 scales mainly in our clinic. One is definitely the GMFCS, which is more reliable and valid also, which talking about the functional status of a child, like the GMFCS 1 to 5. And we are using CFCS, which talk about the communication ability of that particular child. We are using MAC, that is talking about the hand functional or the manual ability of a child, how they are manipulating, how they are using hand, because clinically it's very difficult to differentiate from one child to another child, because they are having totally different presentation when we are discussing about the clinical case. But when we are having some theoretical framework in terms of classification, it's a little bit easy. We are talking about the spasticity, we are talking about dystonia, we are talking about athetosis, we are talking about ataxia. But we all know as a clinical therapist that it's very difficult when we are treating in clinic. Most of the time, the features are not the same as it is in theory. So today we are more talking about the clinical part. On my next slide, it is a little bit about the kids with cerebral palsy, which is more related with the history part. Williams-Jones mentioned about the clinical report for cerebral palsy. That's what the diplegic cerebral palsy or the diplegic cerebral palsy. It's also known as Little's disease. And that is mainly the term for the diplegic cerebral palsy. On my next slide, it is very important. The next slide, it's look like a house. I always explain this thing to parents also, because most of the time, if parents are coming with the complaint that their coordination is not good, their language skill is not good, their fine motor is not good, their attention is not good. The complaints are mostly like this, especially in the kids who are going toward the school. Either they are kids with cerebral palsy or with autism or ADHD. They are usually having complaint about the roof, the component of the roof that is more toward the attention, coordination, eye-hand coordination, fine activities. But as a therapist, the point of treatment is always toward the ground, that is toward the base. Base is talking about the senses. Senses is that is the tactile, the proprioceptive, the vestibular, vision, auditory. We all know that some are extroceptions, some are interoceptions, which is very important to treat. And somewhere in between these two, it's about our own body, like about the body awareness, about the reflexes, about the motor planning. So, like for example, either kids are with cerebral palsy, or if they are normal or the typical development, they are developing through these processes like the sensory environment, sensory understanding of the body, and more exploration with the play, with using different sensation. For one example, like kids around 2.5 months, they start exploring about the colors. The color recognition is better after 2.5 months. Around 3 months, they are understanding the color concept also. So that's how they realize that world is more colorful, and they are searching the different colors here and there. That's how they start developing their neck control in a much better way. It can be vice versa. If kids are having some vision problem, or they are not very good in terms of visual fixations or the color identification, definitely some kids may have delayed neck control. And it may be the opposite, like in kids with cerebral palsy. If the neck control is not very good or it's delayed, definitely the kids may have some vision issues. So there are many cases in which parents are complaining that still I am feeling all things was going normal, but suddenly I feel the focus is different, the attention is different. I always ask them, what about the vision? Have you checked about the visual field or the optometry? So that examination may also be important, because vision is also very important sense for the development, we all know. And other sensory system like the vestibular system, which is the point of discussion for today. The next slide. In vestibular system, this is the one system which is like fully myelinated and fully developed just before the birth, because this is the system which is more related with the movement, which is more related with the position. So this is the system which is start developing in utero, in embryonic period, when the mother is moving, when fetus start movement in the amniotic fluid. That's how the body understand, the fetus body understand that this movement is something different, this movement is something different. That's how the vestibular system start developing. Mostly the myelination of this particular system, I'm talking about the vestibular system, is completed by 16 weeks in embryonic life, and it is mostly developed within 30 to 36 weeks of gestation. Vestibular system, we all know it's a primitive system. It's having different component if we are talking about the physiology and anatomy. But one thing which is very important for me as a clinical therapist, that this system, it's more related about the movement, the position, position of our own body, position of the head, position of the like the movement in the environment. It's the comparison. Comparison means comparison of our own body with the other person, comparison of our own body with the environment, even with the body segment, like the head position in comparison to the body, or the body upper body comparison in terms of in correlation with the lower body segment. So this is a system which is very important. if we are treating our kids with cerebral palsy, even in cases of autism, this is the system which I am going to assess in more detail, because I really want to know whether the kids with autism, they are having issues with the speech, or even they are having issues with the vestibular processing thing. But today we are talking about the cerebral palsy, so we are more concerned about the position and the movement. So on the next slide, it is mentioned about that what is the function, what is the importance of vestibular system. We all know that the position is it's the one trigger point, or is the sensation which is judged by the vestibular system. The position of the head, the position of the direction of the movement, the change in the speed. And we know that I already mentioned it about the vestibular system is definitely it's very much tied with the vision as well as the auditory things, and also with the proprioception, because the kids who are having proprioceptive issues, definitely they have issues with the vestibular processing also. So on the next slide, it is mentioned so many things in terms of treatment. If we are talking about the clinical function, how we can consider this slide is very important, because it's talking about vestibular function, because we are going to treat a child with the vestibular equipments. So we have to know which system or which function is important in that particular case. Like if we are talking about the posture control, if we are talking about the extensor tone, maybe the neck control or maybe the back extensors muscles. If we are talking about the neck control, we have to always understand then how this system is developed within the utero or within the embryonic time. This system it's mainly related or it's simultaneously developed with the neck muscles innervation. So the receptors of this system it's developed at the same time when the cervical nerves develop. So that's how so many things are important during the time of treatment. This is also important for the posture and equilibrium. This is the system which regulate our position in the environment, whether we are leaning toward the right or toward the left. That is also judged by this particular system. Also, we are talking about vestibular system. We can't forget about the tone, because just imagine if I am sitting very stable on my chair and I am talking to all of you, and suddenly if my chair is start moving, definitely I will be more guarded and more my tone will be increased to protect my body in relation with the moving surface. So vestibular system is definitely related with the muscle tone in conjunction with the proprioception, because whenever our body is moving, definitely it will stimulate our proprioceptors, and that's how it's correlated with the vestibular system. Other thing which is important, it's our arousal level. Just imagine there are two kids. One is hyper, one is over aroused, and one is under aroused, who is not attentive for the things. Definitely the treatment in terms of vestibular equipment, use of vestibular equipment, it's totally different. We'll discuss when we discuss about the lab activities, then how we can use the vestibular equipment if one child who is hyper aroused and one child who is not regulated his arousal level. Like it's very common, like if we are talking a case of GMFCS 1 or 2, and we are talking a case with GMFCS 4 and 5, the use of equipment and the techniques are different. Also, we have to understand that the vision field stabilization is also very important. Like if I'm sitting and I'm looking to you or looking on the screen, if I'm treating someone, there are three kind of condition. One is like if I am stable and the surface is moving, the target is moving, and sometime target is stable and I am moving, maybe on the swing, maybe on the balance board, and sometimes the both, the moving object as well as the moving person, the child. So definitely the vision field is also correlated with the vestibular system, because that's how the movement started. That's how the movement recognized by the body. The next slide, the posture control is definitely correlated with so many other things. Like as a physiotherapists, we are more dealing with the motor component, but that is the part of posture control. But that is not only the things, it involves so many other things also, like the sensory system and the neuromuscular system, and also the musculoskeletal system. If any one component, it's either the sensory or either the musculoskeletal or the neuromuscular, any system, or may other things are also there. But if we know about this slide, there's a one term that is the vestibular. So somehow we have to consider our sensory system if we are treating a problem which is related with the posture control. The next slide. Then now we are talking how this systems, how these sensory problems are related with the kids with cerebral palsy. The next slide. We all know that the common problems in children with cerebral palsy, we all know about the muscle tone, either it is hyper or hypo, whatever it is. It's about the movement pattern. It's not in a normal synergy. It's an abnormal movement. It's maybe the due to the hypertonicity, or it's maybe due to the dystonia. It's maybe involuntary movement sometimes, and the asymmetry in movement, the inefficient weight bearing and weight shifting pattern. These are the very common motor problem which is easily assessed by any therapist who are working with children with cerebral palsy. It's very easy to say that the kids are having high tone, or the kids are having asymmetrical movement, or kids may be having abnormal movement pattern. And the common things are about the weight shift. But how these problems, how these motor problems are changing our sensory processing also. So like, for example, the kids, for example, next slide. Then the example, like if kids usually, kids with the cerebral palsy, they are having more flexion extension pattern. They usually in this kind of position that is more toward the chiropractic or the slouch position. It's very difficult for them to go up to a full extension or to look up most of the time, not always. I'm on the next slide. And the kids who are preferring more sagittal plane movement, it's very difficult for them to reach sideways, that is more toward the frontal plane movement, and the most difficult for them to cross the midline and to reach. So it's a very common thing which we always looked in our clinical practice, that they are mostly toward the protective reaction if they are hypertonic. And even the dystonic kids, they are more toward the extension position, that is again more toward the sagittal plane. And just imagine if a child is only preferring one plane movement, they are not having other plane movements or very limited movements in the other plane. Definitely, if your movement is restricted in terms of different planes, the vestibular system is going to be affected, because that is the system which is tuned up with the movement, or which is integrated with the movement. If my movements are very much limited only in one plane, in one direction, definitely that is the part which is going to affect the vestibular system. It's very difficult for the kids who are hypertonic or maybe the dystonic to cross the midline. The kids with dystonia, like just imagine a position of ATNR. It is more the extension toward the face side and more flexion toward the head side. If this position will persist, how they can cross the midline and understand that their body image is totally different. That's how they can't perceive about the midline crossing activity. And unless and until we are not rotating our head, we are not rotating our body in terms of to reach, to play, to throw something in different direction, definitely the vestibular system is not very good tuned with the movement. So the next slide, it's a very much concise way how to understand if kids are having. We all know that the kids with cerebral palsy, they are having poor postural control or inadequate postural adjustment. So whenever the posture is not correct, or they are fixed in one position, not able to easily reach out, not able to change transition is very difficult. Definitely, the different sensory system is involved in that particular case. But in the middle section, what we have written, it's about the vestibular. Unless and until they are not crossing the midline, they are not moving their head in different direction, they are not fixing their lower body and just turning. Just imagine if I am calling you by your name and you will say, "Oh, okay." But if I'm talking to a child with cerebral palsy, either they will rotate their own body or they can't rotate their head at all. So that's how the vestibular and vision, it's very much limited in terms of their tuning with their own body. And also they have limited movement repetition. So that's how slowly in typical development, the kids start rolling, they look up, they look toward the mother, they are moving their head to look toward the family member, and something when sudden light on, light off, new toys there. And if we are talking about the atypical kids who are like developing with some problems, definitely they have limited movement or delayed development. So the body experience with the movement and maybe with the other sensory system, it's very difficult for them, and they don't understand how to move, how to play with that particular in that particular scenario. So on the next slide, so we are talking about asymmetry, which again are commonly explained and clinically judged by so many therapists, that asymmetry or the one side movement is more and one side movements are limited, or maybe upper lower body involvement is different. So whenever we are talking about asymmetry, definitely isolated movement is very difficult for them. The weight shifting is very difficult for them. Just imagine a case with quadriplegic dystonic cerebral palsy. It's very difficult to use their hands in midline. It's very difficult for them to understand, to coordinate their lower body in terms of walking, in terms of playing. So they have so many problems with weight bearing, weight shifting, a problem with bilateral integration, which is very common due to the asymmetrical involvement. So on next slide, it is again a summary which is related with the asymmetry, which again saying in middle section that the head position is affected because of asymmetry. They are more toward the one side. The kids with dystonia, they are either in more flexion, more extension, and it's very difficult for them to sustain the head in a midline. It's very difficult for them to control the mid range for any movement. So that's what the middle section of this slide is talking about, the head position, which whenever the head position is not controlled or the head movement is limited in one direction, definitely the vestibular system development is going to be affected. Uh, so on the next slide, it's talking about the activities which we are going to understand. I'm just give me a minute. I'm moving toward the lab and we'll discuss about the practical things and techniques, how we can treat this vestibular things. In terms of summary related with the theory, I just want to say that whenever we are talking about kids with cerebral palsy, if they are having some problem with the movement, if they are having asymmetry, if they are having tone issues, it's maybe the hypo, or some mix, then definitely the movements are affected. And whenever movements are affected, the vestibular system is not going to work toward the as per the requirement of the body. I hope it is audible with everyone. And now I'm moving toward the other part, that is more toward the practical part. Just give me a minute. Hello, hello, is it audible?
Yes, sir. Yes, sir. Audible and visible, sir.
Okay, thank you. So, if we are talking about the vestibular equipment, the vestibular equipment is always related with the movement, the mobile surfaces. Mobile surfaces may be the swings, maybe the balls, maybe the bolsters, the balance board, and so many other things. But the commonly preferable thing is always a suspended equipment. It's maybe any kind of swing. So just imagine if my aim is something which is related with more toward the neck control. If I'm treating a child related with neck control who is having the primary complaint is about the neck control. But if we understand about the physiology and not me related with the sensory and motor component, as I told you, whenever kids are around 2.5 or maybe 3, they are looking about the world which is more colorful. That's how the extensors muscles are going to develop, and that's how they are looking up, moving here and there. But kids who are toward the cerebral palsy, it's very difficult for them to be in a position. Their hips are flexed, knee are flexed, and they are more toward this supine flexion position. So that's how we are using this thing. If my goal is for the neck control, definitely if I'm taking a child in a prone position on the swing, one thing which is very important whenever we are treating a child with cerebral palsy, the position and the alignment of the body segment is very important, because that's how the biomechanics is talking about. If we are taking a child in prone, it should be supported, and if we are using this thing, the vestibular equipment, it should be in a linear direction, front, back.
One, is it audible? One, two, three, four. One, two, three, four, and then we can ask them to look up, look up, look up. So this linear direction movement is just like moving one, two. So how we can understand about the movement, so that it's something like, so if just imagine this is a moving surface and the child is somewhere like this. So the first movement is like one, and the second is little bit more, the two, and then little bit more, and the three, and the four, and stop and look up, look up. You can use some kind of objects which is maybe some kind of light objects, and you can ask them to look. So we are using the movement for the neck extensions. So it is next one, two, three, four. Okay, very good. So that kind of, because movement and any kind of movement is giving you a sensory input that yes, your body is moving, your body is moving, your body is moving, and any kind of play, maybe if kids are very young, just to look up, that is also a motor component, because we know that adaptive response is very important whenever we are dealing with the sensory component in terms of treatment. So if my goal is somewhere toward the, if I'm having a child who is like GMFCS 4 or 5, they are more involved functionally. So definitely the support will be the more. You can use some kind of inclined surfaces over the swing, or maybe
Hello. So the audio is getting disturbed a little. So the audio is getting a little disturbed. It's not loud. It's coming very low. The audio is coming very low.
Just give me a minute. Just give me a minute.
Sure, sir. This one was better. The voice came right now. That was very good.
Am I audible now?
It's little more disturbed, sir.
Just a
Previously, it
minute.
was coming very fine. Yeah, this is good, sir. Now it is coming fine.
Is it okay?
Yes, sir. Yes, sir. It's good now.
So if the kids are more functional like
There must have been a glitch, technical glitch. Sir must be joining very soon with us. Don't leave. Sir is joined. Yeah, sir has joined us.
So if
Yes, sir.
the kids are GMFCS
His
one
voice
or
is,
two,
voice is coming a little disturbed, sir. I think the mic is a little far away from you.
Hello.
Yes, sir. That is good. This is good, good, sir.
hello.
Yes, sir. It is good, sir. The voice is good,
Is
sir.
it okay now? Is it okay? Okay.
Yes, sir.
Sorry for the disturbance.
Yes, sir. Yes, sir.
Uh, okay now?
Yes, sir. Yes, sir.
Okay, okay. So if we can use different equipment, like if I'm treating a child in terms of sitting, or the goal is somewhere toward the sitting, then definitely if we are using some kind of mobile surface in terms of treatment, if my goal is about weight shifting and training them for the further gait or maybe the standing. So if we are taking a child with cerebral palsy in a sitting position on the moving surface, definitely this movement, the swing can move in different directions, the linear direction, the angular direction. But if we are treating them in terms of their more postural control, in terms of their arousal regulation, then definitely this linear direction movement, that is the side to side movement, or maybe the front back movement, this is more important. But if they are under aroused or they are not attentive toward any play, then this kind of movement can be helpful for them. But please understand, whenever we are starting treatment for any new client, definitely the linear movement, that is the side to side movement, or maybe the front back or the one direction movement is more important. So if I'm arranging some scenario in which I just want them to learn or to understand about the weight shift, because the weight shift is a very common problem in children with cerebral palsy. So the swing or this mobile surface has to move in a different opposite direction in terms of reaching. If I want to use my right hand to reach, definitely the swing has to move in opposite direction, and it's applicable for all the moving surface. Whether we are using the ball, whether we are using the bolster, or maybe we are using some kind of balance board. But if I want to train a child for the weight shifts toward the right side, the mobile surface has to move toward the left. Same thing if I want to teach the weight shifts or something toward the left side, the swing has to move in the opposite direction. So if my goal is something in terms of sitting balance, or maybe in terms of even in standing, if my goal is in kids with GMFCS 1 or 2, if my goal is to kick a ball, then definitely the weight shift is very important. So if my vestibular component is a problem, or it's in my problem list, then definitely I have to train them over the vestibular equipment. If I'm using the swing for this particular training, then I will ask them to reach and then move and give it to mama. Then go reach and take and give it to mama. So that's how we have to train them in terms of weight shifting. Sometimes we can combine the movement like the weight shift and some kind of extension. Even we are using in terms of alternate pattern, the position and the alignment is very important whenever we are treating a child with cerebral palsy on some mobile surface. We can't compromise the posture. So if they are more stable, it's okay. If they are not, we have to use different things Sometimes we need to give them more support. Sometimes therapist has to sit behind them just to maintain the posture. So even for the leg training, we are using uh, some kind of toys. Maybe we can ask them, okay, my goal is kicking, so we can ask them to roll and come back, roll and come back. That will also give you knee flexion extension training. But my goal is somewhere kick a ball. So this is kind of play, maybe with some textures or maybe with some kind of resistance also. The other activity which is very important, how we can start over equipment if we are training them. Always the prone position is the foremost position in which the training is important. So if my goal is something related with, if I'm talking about the PT goal, and if my goal is about the sitting and playing, if my goal is to talk toward the mother during the time of feeding, that also need this kind of extension. So in for that particular goal, we can take some toy and we can ask the child to look, where is mama, where is mama, where is mama. That kind of position is very important, because the lower body is more toward the movement and the upper body is more fixed. Even for the kids, if the goal is about the feeding and writing, definitely the hand position is very important. So we can use, there are so many pictures in slides which is mentioning about what activities we can use. But in this position, my main purpose of movement is to go and come, and go and come. That kind of symmetrical weight bearing is very important whenever the kids are having dystonia, and if they can't use their hand in a proper symmetrical pattern. Even sometimes we are using pedidep to block the elbow, otherwise they are more like this, and then we can give them external rotation and little bit external rotation and little bit compression to ask them to use their hand as a base, and then look up and reach at too high to draw something. And these kind of position is very important for the training over the movement. So always, if you are treating a new client for the vestibular rehabilitation or kids who are having vestibular problem, according to your assessment, start with some kind of prone position which is more stable, large base of support, so they are more confident that yes, this kind of movement. Because just imagine if a child with quadriplegia, spastic quadriplegic, for them a little movement, it's too much for them. So we always prefer to use some kind of prone activities, start with some kind of prone line activities, so they are more supported, more stable. Okay, so go. 1, 2, 3, 4. If after 2, 3 sessions you feel that they are more confident, more stable, I'm talking about GMFCS 4 and 5. They are more dependent, they are more involved. But if in cases of GMFCS 1 and 2, definitely you can use different position, maybe the sitting at the corner, ask them to hold the swing, and then you can give them some target, like side to side moving, and then reach, then side to side moving, and then reach. So this kind of movement and combination of functional activity give you more alertness in terms of your posture control, the arousal level, the attention. Definitely it can be helpful. The common thing which is very commonly available in clinic, it's about the ball. Ball is also a moving surface. It gives so many things. We know therapists using ball for many purposes, but I have seen in terms of cerebral palsy, we are just taking the kids on the ball and we are start moving or bouncing. But but if you really want a child to register the movement, the direction and the movement magnitude, it's very important. So just imagine if I'm taking a young kid over the ball, definitely the first and important part, to give them a base, to press them down and give them a security of movement, that yes, you are more secure over the ball. If we are just taking the child over the ball and just start bouncing, it's not going to register. It's just a movement to make them more alert, but it is the movement is not going to register. So just imagine if a child is very young and taking the child over the ball, then give them first a compression, downward compression, and then always start the movement. So if I'm taking a child over the ball, then I will give a downward pressure, and then only the movement side to side, or maybe the front or back. It's depend, case to case. It's depend, but this thing, it's very important. And always understand, do not give them so many bouncing movement, because this is not going to help them. It's just mess up all the sensory system. So just give them a downward pressure and then move. Give them a downward pressure and then move. And always understand one principle whenever we are using any mobile surface, either a ball or swing or anything. So if my movement is toward the right side, the ball has to move toward the opposite direction for any mobile surface. If just imagine, if I'm sitting on the ball and I'm reaching toward the right, and if ball is also moving toward the right, it is more asymmetrical and more flexion, side flexion, which is very common problem in children with cerebral palsy. So if my ball is moving opposite direction and I'm moving, then only the weight shift is possible. Then only the weight shift is possible. So these principles are important. I can't give you the direct recipe for the activities because there are so many things according to the case, but the principles are always same. If I want to train them for the weight shifts, definitely the mobile surface has to move in different direction. Even we could use the bolster, which is easily available in clinics. If the vestibular system is the target in terms of treatment, then they have to sit. There are so many other activities, but the purpose of weight shifting is definitely, if my reaching or my weight shifting is toward the right side, my bolster has to move toward the opposite side. Same thing in this also. If I'm reaching toward the left, the bolster has to move. So it should be this movement of bolster. It's mainly guided by therapists. It's not by the child. If child is sitting, and if I'm asking them to reach, then my pelvis has to move this bolster toward the opposite side. Then only this movement is automatically generated by the kids, because they are not ready to reach toward the in my command. According to my command, they are not ready to move toward that direction. So it's my duty to move the bolster toward the opposite side, so that the pelvis toward the weight bearing side will be more loaded, and they can reach toward the same side, which is very important for them. Even the kids who are like GMFCS 1 and 2, sometimes they are walking, but still the transition between the stance phase and swing phase, it's very difficult for them. So that time also we are using these kind of activities in the standing position, because this mobile surface will give you more loading, deloading, loading, deloading, which teach them, okay, take that step, take that step. Because if I'm moving the bolster toward that side, the left side, definitely the left foot is more loaded. So it's easy for them to understand to take the right leg up. And then same thing to take the left leg up. Even we are using swing for that this particular purpose. My training is for the walking, or maybe for the kicking or something. We are taking the kids in a standing position over the swing with proper support, proper alignment. I'm always saying the alignment and the posture control is very important before starting any advanced treatment. So take them in a proper position. If they can stand without support, then definitely it's okay. If they can't stand, but so they require more support, maybe your own body. Then if I want them to reach right, then they have to move, means the therapist has to move the swing toward the opposite side. That's how the same thing that's important, which is important for to load and deload. So we can use different swings, whatever it's available, and whatever it's required as per the child. Sometimes kids who are very young, more involved, and the age is around some months, maybe the 6 months, 7 months kids. These kind of swings called Lycra swing. Can you know this? This kind of swing is important, where you can give them a base. They are more secure with the Lycra, and they can understand this kind of bouncy movement, which give them a position sense in terms of environment, where I'm moving, right, left, because this gives extra proprioception to the child to understand their own body position in relation with the environment. You can use so many toys, different toys, but always understand whenever whatever sensory equipment we are using, either the swing or ball or maybe booster, but need some adaptive response. That adaptive response is very, very important for the registration of the movement. Just imagine if I'm taking a child on the swing and I'm saying I'm treating them and I'm moving, moving, moving. This is not going to toward the treatment. It's just a play. But I'm always saying the pediatric therapy, it's a purposeful play. I want them to solve a purpose. That is the movement, and do some activities. That can be anything according to you, according to your creativity, what activity you want. But I always want to register that movement, to register that sensory input and use it. It can be a toy, it can be a hi-fi, it can be a song, anything. The output is important. That is what we call adaptive response in terms of sensory integration therapy. We can use other activities which is commonly there. Like if my goal is about the gait training, my goal is about the weight shifting, then definitely the balance board can be helpful. But it's again the same. That is, if I'm using my right side to deload, then definitely the tilt board has to move toward the opposite side and reach. Even I'm treating kids in sitting position in 1990, sitting on the bench, and then we are using this balance board as a weight shifting equipment for the training. Sometimes, like kids with spastic cerebral palsy, the pelvis movement is very difficult for them to understand this anterior posterior pelvic tilt. Then only we are using bolster swing just to train them about to move front and back, or maybe to reach in different direction. So it's not about the equipment, which equipment we can use, but it's about the technique to understand that we need different movements in different directions, but it should be in a limited range. It's not that sometimes parents are saying every day he's doing swing at a home, all the time he's on the swing, he's happy. But believe me, if kids are all the time on the swings, that's how the comments from the parent side. I always ask them why they are doing throughout the day, because they are not going to register. This movement is not going to register by them. That's what they are just moving. They are moving their own body. They are swaying their body in different plane, but they are not able to understand that what's the purpose of this movement. That's what they are moving. They are shaking. There are some kids who are like microcephalic cerebral palsy cases. They are most of the time they are moving their head. They are shaking their body because it's difficult for them to register, to make their own body awareness. So that time these are the few techniques which is very, very important. In terms of case, if a child is walking but still the transition is difficult, definitely that is the case which require more vestibular activities. In terms of severely involved cases, uh, they are playing, but the sustenance of that particular movement is difficult, then definitely that is the case which require more kind of prone line activities over the vestibular equipment. If a case is like with small magnitude of sound or maybe the movement, they are more alert, they are more, they can't sustain a position, then definitely they require more kind of uh, vestibular rehabilitation program. If imagine if a child is able to see but can't differentiate between the two objects, or maybe they can't look the object which is look like two different pictures, or maybe they are having some writing issues, or maybe the coordination, eye-hand coordination problem. These are the some cases for me who are in preference for the vestibular rehabilitation program. Even in other cases, these big activities can be helpful, but presently we are talking about the cerebral palsy. Then definitely, if we are going through the definition of cerebral palsy, they have all motor, but if we are think about it, then definitely it's a secondary sensory processing dysfunction. And today we talked about the vestibular things. I hope it is helpful for all of you. I don't know everyone, each and everyone personally, but I know you all are a good therapist and practicing with so many patients every day. But for the clinical reasoning, the concept can be helpful to understand if the kids are involved, if you are gaining your result around 99.99%, but still if you feel something is lacking, then try some vestibular activity, which is really going to be help you in most of the cases. But if you want to know about some individual cases or individual topics, then definitely in future we can discuss something, or you can email me in terms of for your own case. Thank you. Thank you so much.
Thank you so much, sir. That was really, really so wonderful. I must say that I really became your fan after this. It was such a wonderful demonstration of pediatric rehabilitation techniques we have demonstrated. So wonderful that was. I think sir has had some technical glitch, so must be joining, and then we'll be taking questions. So in the meantime, if you people have any questions coming here, so you can. Okay, sir is here. So in the
Yeah, sure,
meantime, if
sure,
you have
sure.
any questions here. Okay, so we have a question here in the comment box coming up here. Let me take it on onto the screen. Okay. They want to ask what measures should we take to prevent sacral sitting?
So if a kids, like usually the young kids, they start sitting in sacral position. So we can use these kind of wedges, which will give like the kids who are sitting in sacral position. Then if you are using these kind of wedges for the side sitting, definitely it will give you more anterior pelvis tilt. And whenever the kids are toward the anterior pelvis tilt, then definitely it can be helpful to prevent the sacral sitting. And also sometimes we are using the sensory things, that is what we call even that swing, the bolster swing will help you. That's how I told you, it's kind of horse position. That's how the pelvis is moving anterior posteriorly. And also it depend on the reason. Most of the time the sacral sitting is due to the hamstring tightness in kids with cerebral palsy. So yes, it can be helpful. The anterior posterior movement over a bolster or maybe a bolster swing can be helpful.
Great, sir. We have one more question, sir, coming up here. Okay, sir, can you please update us on importance of sound therapy in CPHO?
See the sound. See, I am also certified in auditory integration program, which is like having different sound pieces. Actually, it's a different app which you can download, but it is all it's all on the purchase on the same. So, but I feel if you are treating a child for the cerebral palsy, you can use some kind of instrument music, which is easily available on different applications. But always use the vestibular things and then integrate. Like imagine if I'm using a drum and the kids is on the prone line over the swing, and I'm giving 1 2 3 4 5 and tap the drum, so they have to understand from where that sound is coming. That's how we can start for the young kids or more severe kids. But if kids are like GMFCS 1 or 2 who can understand the command, or who can understand or can recognize the direction of sound, then definitely you can use some kind of rhythm. Or even there are some pieces which we are using clinically, some kind of dham 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 rhythmical movement, more toward the instrumental pieces of music. Yes, you can use it with the swing. I am personally using for the kids with autism who are like more toward the hyperactive. Then we are using the Lycra Swing with the music, which is more rhythmical.
All right, sir. So we getting so wonderful feedbacks in the comment box. Rather, you and everybody who will be listening to you in further also, because this video will be staying here on YouTube. So everybody who has attended this webinar, so we all are quite awestruck, and we are really had a wonderful clinical insight from this, because personally I don't treat too much of neurological cases, but that was really so interesting. I think I told you the same thing the last time also we had a
Yeah, I remember
conversation.
that.
I always, whenever I listen to you, I start developing interest towards pediatric neurology. So
Oh,
I think I should
that's a
completely
winning
take the
point for me.
Indeed, sir, indeed. So thank you so much, sir, for coming here and giving time to the people who are listening here on Jaipur.
Thanks to you, Dr. Himanshu, and thanks everyone. I hope it can be
Yeah,
helpful for you and your clinical practice.
YouTube channel.
Thank you.
In, indeed, sir, indeed. Thank you so much, sir, for being here, and we'll be looking
Thank
forward
you,
to have many.
everyone. Thank you.
Thank you so much.
Oh, it's my pleasure.
Thank you so much.
Thank you.